Hello, everybody. Welcome to the LabRoots 15th Annual Clinical Research and Diagnostics virtual event. My name is Vishnu Samara. I'm a clinical assistant professor of pathology and assistant director of clinical chemistry laboratories at the University of Chicago School of Medicine. Today, I'm going to talk about HbA1c assay methodologies and proficiency testing to ensure accuracy in diabetes management. And I have no financial relationships or any other disclosures relevant to this talk today. So I have divided my talk into 3 sections covering those respective objectives, starting with understanding the background of diabetes and importance of HbA1c for diabetes monitoring, reviewing the various methodologies and best practices for HbA1c testing, and finally to evaluate the role of NGSP and CAP proficiency testing program for HbA1c. So to begin with, in understanding the background about diabetes and A1C, diabetes is a disease characterized by high glucose levels in our blood, and the disease is a major problem not only in the United States or North America, but all over the world. And in 2021, the statistics show that 537 million population were affected by diabetes. And in the next 20 years, by 2045, it is expected that almost 800 million population will have diabetes. And within the United States, 38 million population, or close to 10% of the population, have diabetes. And the interesting thing is 1 in 5 among them doesn't know that they have diabetes. And another challenge is this pre-diabetes condition, which is currently affecting almost 100 million American population. So 1 in 3 of them have pre-diabetes, and another challenge is more than 8 in 10 of them do not know that they have pre-diabetes. And the main problem in diabetes is not just the elevated glucose levels, it's the complications that bring major disadvantage to the system, where the increased glucose levels can cause brain stroke, cerebrovascular disease, cardiovascular diseases, diabetic nephropathy damaging the kidneys, neuropathy damaging the nerves, retinopathy damaging the eyes, dental problems, vascular diseases, and then also foot damage. You might have heard from your family, someone who has affected with diabetes got their foot amputated or their toes cut off. So how this all came into the picture for HbA1c is there was a landmark clinical trial that was happened in 83, like roughly 4 decades ago. It's called Diabetes Control and Complications Trial, DCCT, that ran for 10 years. At the end of the trial, the study further continued as what is called the EDIC, which is Epidemiology of Diabetes Interventions and Complications, which is currently ongoing. In the similar time period in the United Kingdom also, there had prospective diabetes study that went from 1989 to 1998. And at the end of this DCCT and UKPDS, they have established that HbA1c can be used to monitor glycemic control. And one of the major findings from that study shows that the patients that were monitored for over the 10 years, depending on their A1c percentage, they also had their rate of retinopathy progression. So the higher the A1c levels they have, and their retinopathy or eye damage was much worse, and the lower the A1c they had, their retinopathy or their eyesight is much better. And HbA1c is reported as a percentage of total hemoglobin. It is the amount of HbA1c that depends on the concentrations of glucose in our circulation, as well as the lifespan of RBC. So the typical lifespan of RBC is roughly 120 days, which is 4 months. So the A1c levels actually reflects the glucose concentration over the preceding 8 to 12 weeks. And hence, A1c is used to monitor, diagnose diabetes, and also assess the risk in patients with diabetes for stroke, acute coronary syndrome, and other vascular complications. And so in a normal individual, a HbA1c percentage of 5.7 and below is usually seen. And if somebody has an HbA1c between 5.7 to 6.4, they're considered pre-diabetes, and someone who has an A1c of 6.5% and above are considered diabetes, or individuals with poor glycemic control. And we can also correlate the HbA1c percentages with the estimated average glucose, where the individuals with 6.5% and above A1c has around 140 milligram per deciliters of glucose or above. And the information about HbA1c and several other tests that are used for management of diabetes mellitus as well as diagnosis are available in ADLM guidelines in this paper that was published a year ago. And coming more specific to the A1c, which is a part of glycated adult hemoglobin among the hemoglobins present in individuals. So there is various types of hemoglobin. There is HbA, which is the adult hemoglobin, which is made of alpha 2 and beta 2 chains, which are polypeptide chain proteins, which constitutes 90% of the hemoglobin. And then there is HbF, fetal hemoglobin, made of alpha and delta chains. And HbA1c is the alpha beta connected with glucose. And looking deep into the mechanisms of how this happens, whenever there is increase in blood glucose levels, the glucose can freely enter the red blood cells. Once it enters, it can go and glycate several regions, but the glucose that glycates at the terminal valine amino acid of beta chain is specifically called as HbA1c. And it is a covalent linkage, non-enzymatic mediated, and it is very strong. And other proteins can also experience this process. So that's why we see non-A1c fractions of hemoglobin also, and then non-hemoglobin glycated proteins in our system. So the adult hemoglobin with the glucose or carbohydrate moieties are the A1. So there is A1, small a1, and then there is A1A2, A1B, and then there is A1C, which is formed by what is called a Amadori product formation. So where the glucose levels react with the amino terminal amino acid of beta chain, forming a strong bond, and this bond doesn't go away once it is formed. So the A1c concentration depends on the lifespan of RBCs. And A1c represents 85% of the glycated hemoglobin, and clinically several assays measure A1c. However, there are some assays that can measure total hemoglobin, glycated hemoglobin also. So you want to look at your package insert or method sheet carefully to understand what your assays exactly measure. And I'm trying to understand more about hemoglobin, which is a large 4 polypeptide chain protein present in RBCs, that is an oxygen carrier. It is made of heme and globin molecules. There is 2 alpha chains and then 2 beta chains. All the polypeptide chains are made of different amino acids. And there are a lot of hemoglobin variants that occur due to mutations. And in these mutations, there is replacement of one amino acid with other amino acids. Especially the most common one is sickle cell hemoglobin, where in sickle cell variant, the glutamic acid at the 6th position of beta chain is replaced by another amino acid, valine. So that also replaces a charged position of the amino acid in the glutamic acid. And this is a heterozygous condition. When there is a homozygous condition, it makes the hemoglobin more sickled, and then the RBC also becomes sickled. And in the United States, hemoglobin S is prevalent in 8.3% of African Americans. And then there is other variants such as HbE, C, and D are also seen in different patient populations. And each of these variants, they have changes or mutations in different positions of their polypeptide chain amino acids. And they can be either a heterozygous or a homozygous condition. Usually in a heterozygous condition, we may not see any clinical manifestation. However, in homozygous condition for sickle cell, which is sickle cell anemia, and for HbCc, EE, and DD, there is hemolytic anemias these patients are experiencing. Now that we have understood the background about diabetes and HbA1c, I would like to talk about the various tests or methodologies available for A1C, and then what are some of the advantages and disadvantages of these few methodologies. So clinically, there is two analytical approaches that labs can utilize. Some of them are based on structural difference, which include immunoassay, boronate affinity HPLC, and then enzymatic assays. And then there is charge difference based assays that include ion exchange HPLC as well as capillary electrophoresis. And labs can use any of these assays based on their workflow and the patient population. However, all these methodologies or assays should be NGSP certified, which we will talk towards the later part of this presentation. And they also need to be IFCC, which is International Federation of Clinical Chemistry, standardized A1C assays. However, American Diabetes Association does not recommend using point-of-care methods to diagnose diabetes, but they can be useful for monitoring diabetes in certain critical situations. Coming to the first method, the immunoassay, which is the most common methodology in use because it is, most of the immunoassays can be automated, available on your automation systems, whether it is Roche, Siemens, or Abbott, and it is a structure difference-based test. And as you all may be aware, immunoassays involve antibodies. So these assays have antibodies raised against the glucose linkage that can identify the glycated molecule along with the first 4 to 8 amino acids on the N-terminal of the beta chain of hemoglobin. Typically, the signal is either a light scattering / turbidity caused by the agglutination of interacting particles using latex tagged antibodies. So the advantages, as I mentioned, it's a highly automated assays. There is good precision, and many vendors are available providing these methodologies. And however, HbA1c and C have mutations at the 6th amino acid. And some of the challenges using immunoassays is, you may not be able to identify if there is any hemoglobin variants. And also when there is high amounts of hemoglobin F, the fetal hemoglobin, more than 7%, you may get lower than expected HbA1c values. So looking into the mechanism of these immunoassays, the rate of the reaction in immunoassays is measured turbidimetrically for A1C, and it is inversely proportional to the amount of HbA1c in sample. So consider a situation where there is not enough A1C or low hemoglobin A1C in a patient specimen, and these represent the latex particles with antibodies, and these are the synthetic glycated molecules. And so there is a lot of agglutination between these synthetic peptides and latex particles. And so there is more agglutination and then high turbidimetry signal when there is less patient A1C. And these are available on the Roche as well as Beckman-Coulter. The Roche one specifically is called as turbidimetric inhibition immunoassay or TINIA assay. Whereas when there is high HbA1c concentrations, in that situation, all the latex particle coated with A1C antibodies, they go and react with the patient's A1C, and the synthetic glycated peptides are freely available. So there is less agglutination and low turbidimetry signal, and the signal is inversely proportional to the A1C concentration, as you can notice from this graph. So high A1C concentrations in the patient blood results to because of low turbidimetry signal. And moving on to the next method, the boronate affinity chromatography. As the name suggests, it's an affinity-based method. And boronate or boronic acid, it's a chemical that has strong affinity for glycated hemoglobin. So in this reaction, you notice that boronate affinity matrix can react with glycated proteins. Here in our situation, it's glycated hemoglobin and forms a tight bond in the reaction mixture. So looking at one specific example, so these boronate affinity chromatographies, they're carried out using a column, and there is mobile phases available. So a typical LC system based methods. This is HP9210 Premier instrument from Trinity Biotech, and these are all the different hemoglobin EDTA specimens available for testing. And so once you have a specimen available, so you have to lyse the blood, and once the blood is lysed, all the hemoglobin and then glycated hemoglobin are released, and this is the columns boronate matrix. And once the specimen is run through these columns, all the initial non-glycated hemoglobin passes through the column, whereas the glycated hemoglobin goes and binds with this boronate matrix. And the non-glycated hemoglobin also elutes first as the peak 1. And when the column is run through a different mobile phase with different composition, the bound glycated hemoglobin in the column is also eluted as another peak, which is the glycated hemoglobin. So compared to the other methods, this method specifically identifies only the glycated hemoglobin, but not specifically A1C. However, it is standardized to the NGSP method, so it still gives an accurate A1C results. So based on the peak 1 and peak 2, you get an HbA1c value from these two peaks. Variant hemoglobins can affect the HbA1c value, but very little amount. However, you will not know the presence of if there is any variance present in the patient specimen. And several commercial methods are available, and boronate affinity is one of the third most common technique that is used in the clinical labs. And as I point out that there is a lot of variants available because of mutations. If you look at these variants, all the variations are in 6th position, 26th position, 121st position, but the glycation is actually happening at the internal first amino acid position of valence. So you can still be able to measure a relatively accurate A1C using boronate affinity method. And also there are several factors that affect HbA1c levels. The first and primarily one includes the concentration of glucose in circulation over the past 8 to 12 weeks and the lifespan of the RBC. So there are conditions that can shorten the RBC lifespan, like hemolytic diseases where there is red blood cell death continuously in G6PD-H deficiency, or some of the hemoglobin unstable variants, or chronic malaria. Or in a prolonged RBC lifespan condition, you can see falsely elevated HbA1c in conditions such as iron deficiency or vitamin B12 deficiency. And there can be some factors like acute or chronic blood loss, pregnancy, and neonates. You can see different concentrations of A1C that are affected. And this table also points out that these different variants have different lifespan. The adult hemoglobin has a common normal 120 days lifespan, and then other variants have different lifespan, with the HbCC variant being one of the lowest one, along with HbSS, which is the lowest, 20 days. And these all factors can affect the glycated hemoglobin or A1C levels that when you're trying to measure. And the next method is an enzymatic method. This is one of the most recent methods that was developed by the vendors. And in this method, as the name indicates, so there is an enzymatic process involved. So once the blood cells are lysed, they undergo an extensive protease digestion. As I mentioned, hemoglobin has 4 polypeptide chains, so it's a protein. So when they undergo proteolysis, all the amino acids are released. So the terminal valine is released, and this undergoes another enzymatic oxidation by fructosyl valine oxidase enzyme that produces hydrogen peroxide. And once hydrogen peroxide is produced, it has capability to convert any colorless compound to a color. So based on the concentrations of valine and the enzyme activity and the formation of H2O2, there is a colored compound formed, and the formation of color is proportional to the A1C concentrations. So you can get the value of HbA1c. And there is different calibrators available, so you can establish a calibration curve. By using that calibration curve, you can get a value of HbA1c. And as I mentioned, it's one of the recent techniques available, and commercial assays that are available on the market include both from Abbott as well as Siemens. And this method also cannot detect the presence of any hemoglobin variants in the patient specimens. And these three methodologies that I described so far are the immunoassay, boronate affinity, and enzymatic, are based on a structural difference because of hemoglobin bound to the internal valine amino acid. The next methods, starting with ion exchange HPLC, which is the second most common method. It is based on a charge difference, and it is the original method that was used in the DCCT clinical trial, which is one of the landmark clinical trials I mentioned. And in 1993, when the NGSP was just around beginning, they also used this HPLC DCCT method to standardize HbA1c. And some of the vendors or methodologies available include both from Biorad as well as TOSO, which are in appearance similar to the other affinity chromatography method, but the principle differs, where in affinity chromatography, it's affinity mechanism, and then in ion exchange HPLC, they have charged columns. So the mechanism includes that, the column has negatively charged matrix material, and this is the direction of the mobile phase. And when you run different charged molecules, such as weak positively charged hemoglobin and strong positively charged hemoglobin, and when you pass mobile phases through this column, once hemoglobins are bound, the weakly bound hemoglobins are the ones first to be displaced by the weakly charged salts, followed by a different mobile phase composition. The strongly positively charged hemoglobins also get eluted. So we can understand the differences in these elutions and peaks to calculate the A1C concentration. So vendors have taken the advantage of these principles. And if you notice this, so this is the flow of the buffer. And when different hemoglobins are passed through the columns, so they come out at different times. So these are the elution times. And you can identify whether some peaks are either hemoglobin A1c or other different hemoglobins. And this is the actual image from a ion exchange HPLC system, where you can identify HbA1b, HbF, the fetal hemoglobin, the HbA1c, the glycated hemoglobin of interest for diabetes testing and management. And then you can also identify some hemoglobin variants such as HbSc, D, and E. And by calculating the area under these individual curves, you can actually calculate the percentages of individual hemoglobin fractions. And overall, cation exchange HPLC methods can detect other hemoglobin variants, including S, C, D, and E. And if there is any of these variant hemoglobins present, it can affect the results in a variety of ways. So the variants that elute along with HbA1c can cause falsely elevated A1c result. And the variants that elute along with common normal adult hemoglobin may cause a falsely low HbA1c result. And so other limitations include, if there is any HbF concentrations of more than 20%, this can interfere with the actual HbA1c result. So because there is a lot of variance present, and then there is also a lot of different methodologies available, labs have experienced these challenges and then situations, and then patient populations are so unique that they have identified or noted a lot of abnormal hemoglobin A1Cs, as well as variants that they have identified, as you notice in these clinically published papers from different regions across the globe. Significantly high HbA1c in diabetic patients, and using one method they had high A1c, and with another method they had undetectable A1c. So these variants and methodologies can interfere with your patient A1c levels. So you want to understand your patient population, then use an appropriate method as possible. And moving on to the last method, which is capillary electrophoresis. And the name suggests that electrophoresis methods depend on the electrophoretic mobility in the presence of a buffer mechanism. The charged molecules can move, and here the sample is present in one electrode region, and then they can move to the other electrode region by supplying a high electric voltage through a capillary. So this is a capillary system from Savia. And if there is any two hemoglobin species that are of the same size, the one with a greater charge will move faster. And variant hemoglobins are usually seen in this methodology and often do not cause any analytical errors, as long as you have verified and validated the methods appropriately. So you can identify whether there is HbA1c or different variant fractions are available. And you can also identify these individual separate variants with a good peak resolution. And most of the capillary electrophoresis instruments have multiple capillaries, which means that at the same time you can measure multiple samples. So there is 8 capillaries as well as 12 capillaries available from individual vendors that you can take advantage of. So looking at a normal individual who has a high concentration of adult hemoglobin, a normal HbA2 and HbF, and this individual hemoglobin A1c is 5.1%, indicating that their A1c levels are normal. And another individual specimen who has normal adult hemoglobin but has an A1c of 8.3%. So you can notice a difference in the peak heights. You see, with a A1c of 5.1%, the peak is shorter, and then with an A1c percentage of 8.3, the peak is relatively thick and taller. And you can also identify different hemoglobin variants using capillary instruments. So you see there is adult hemoglobin, and this individual patient also has sickle cell hemoglobin along with some HbA2 and then HbA1c. And using this capillary method, you can also identify other variants such as HbC and HbA0C. And so using capillary method, as it can have multiple peaks and the peak resolutions are very good, we can identify adult hemoglobin, sickle cell hemoglobin, HbA1c, and then also glycated versions of sickle cell hemoglobin rather than A1c alone. So the glycated version of sickle cell hemoglobin is called HbS1c. So now we have reviewed different methodologies available for HbA1c. There is immunoassay, boronate, and enzymatic, which are structure-based and they cannot detect variants, whereas ion exchange and capillary are charge-based and they can help detect variants if there is any present in the patient specimens. So far we have covered the background about diabetes, HbA1c, there is hemoglobin variants, and then there is various methodologies available for A1c testing that you can take advantage of based on your patient population. I want to talk about the role of NGSP and CAP proficiency testing program for HbA1c. So CAP is the College of American Pathologists that offers proficiency testing services. And for HbA1c, it's GH5 survey that is conducted 3 times a year. So you have 3 surveys per year. And in each survey, CAP sends 5 specimens to the labs to test. And once the labs receive these specimens, we don't know the values in the beginning, so we test the specimens similar to patient specimens, and then we submit the results to the CAP for us to evaluate our results along with our peer lab results to verify how close we are in the entire system and testing process, and how our labs are performing the tests for HbA1c along with other tests we are under the CAP program. And NGSP, which originally started with the name National Glycohemoglobin Standardization Program, officially began in the 1996 to follow the AACC guidelines for diabetes and HbA1c management. And NGSP actually sets the CAP targets for all these proficiency testing specimens that we receive. And NGSP does multiple other functions. They also help manufacturers as well as laboratories, for calibration certifications, and then they also help with the CAP proficiency testing. And if you look at the CAP subscribed labs for HbA1c testing over the last 3 years, there is different manufacturers are available that different labs use, and over the time the statistics have changed. Some labs have taken advantage of some methodologies and they have uh, changed the methodologies, and some labs have reduced one different methodology, and this covers all the methodologies that I have described in the last several slides. And so overall, in 2023, the CAP survey summary includes close to 1,500 labs that are using immunoassay, the most common one, followed by unexchanged HPLC, enzymatic methods, boronate affinity, and then capillary electrophoresis all together include close to 3,000 labs under the CAP HbA1c methodology. And I just want to quickly recap that there are several factors that affect HbA1c levels, and different variants of hemoglobin have different lifespan. And some of the cases that I mentioned, based on the methodology that your lab is using, you can be able to identify or even miss some different patients with some novel or even existing known variants based on the methodology that labs use. So because there is a lot of variation, a lot of challenges, and then HbA1c is such an important test for diabetes testing, NGSP has conducted a lot of studies, and then they evaluated the interference from these common hemoglobin variants such as C, D, E, and S traits on measurement of A1C for 15 different methods. And as you notice here, so this is the HbA1c value, the percentage A1C, and compared to the reference method that they used is HbA9210 premier method. So each methods, from different vendors for different variants have variations. So, but high variation was seen for AD hemoglobin variants, and especially the B101 and DCA Vantage have the most you know, variable results, because these are point of care devices that are not commonly used in the initial diagnosis or monitoring of diabetes. So depending on the method that you are using and your patient population, your variant can affect the A1C result. And so NGSP has all this information available in their website for different methodologies from various vendors and for different common hemoglobin variants. And so what NGSP has done is, over the last 3 decades, along with standardizing the HbA1c testing, they have also focused on improving the HbA1c measurement, because various methods can affect the measurement process. And so they help in standardizing, as well as, if you see here, the standard deviations of all these measurements compared to 1993, this high variation has reduced so much in the last few years. So NGSP has really done a great job in improving the A1C testing process. So now, currently, a few years ago, HbA1c was not a regulated analyte until 2019. So in 2019, CMS and CDC proposed a rule change to regulate A1c, and then they have set a criteria for A1c to be plus or minus 10%. And this caused some disappointment in the clinical community that the cap limit was plus or minus 6%, and then the NGSP method certification was at plus or minus 5%, and CMS suggested to use a range of plus or minus 10% acceptability criteria, because this is such a clinically important test for diagnosing diabetes, treatment, monitoring, and establishing glucose-lowering therapies. With the recent CLIA rule in July, that will be effective from January 2025. The discussions among the clinical community from CAP, NGSP, and ADLM have helped to discuss with CMS and reduce the acceptability criteria to plus or minus 8%. And however, the labs that are currently under CAP proficiency test, accuracy-based proficiency testing, they will still have to meet the plus or minus 6% target value for HbA1c testing, whereas the CAP will provide 2 evaluations, starting with the GH5A 2025 survey to meet both CLIA target values as well as the CAP checklist requirements, especially if you are a CAP accredited lab. And so I have reviewed background of diabetes and A1C, various methodologies for A1C testing, and then the role of NGSP and CAP proficiency testing programs. To summarize, A1C, especially HbA1c, is used for screening diabetes and monitoring of diabetes. There is 5 different analytical methods available, and you can use a fully automated method, or you can use a suppression-based procedure for variant testing, and you want to choose a method appropriate for your patient population and then diagnostic setting. And analytical difference from hemoglobin variants can still be a concern based on the A1C method that you are using, and you don't want to use a point-of-care method to diagnose diabetes. And NGSP provides certification for manufacturers as well as clinical laboratories. And the CAP NGSP criteria acceptability for HbA1c is plus or minus 6%, and then CLIA acceptability criteria is plus or minus 8%, starting from January 2025. And Here are some of the references that I have used for my presentation today, with links with ADA, diabetes website, NGSP, and some of the vendor websites. And I'm happy to take any questions now. Thank you.